Poster GERARD GOH is considered international diabetes and diabetes audiologist from 2014 until now. The head of international radiology of Anfresh Hospital, Melbourne, Australia. Advanced clinic professor from 2020 to now. Department of Surgery, Central Clinic School, Monash University, Melbourne, Australia. Honorary Fellow from 2020 to now. Of National Trauma Research Institute, Melbourne, Australia. Poster Gold, please.
Thank you very much for the kind introduction, Mr. Farrell. I'm going to be talking about genicular artery embolization for osteoarthritis, which is a relatively new procedure that us as interventional radiologists can offer. So these are my disclosures. So osteoarthritis is a very common condition in patients worldwide. And in fact, particularly within the knee joint, it is a very common disease. And because the knee joint is a weight-bearing disease, we know that patients are continually mobile throughout their lives. And so we see a lot of osteoarthritic disease in the knee compared to other places within the body. It is very common. In fact, many patients above the age of 65 are affected to some extent, some minor, some major. And it's the most common joint disease in the world. There are lots of different grading systems for osteoarthritis, but one of the most commonly used by orthopedic surgeons is the Lawrence grading system that is ranked from KL0 to KL4. And the severity increases as the number increases. And so we can see obviously on the far left that there's very minimal radiographic change. There's perhaps a little bit of joint space narrowing. And on the right-hand side of the screen, you can see quite severe osteoarthritic disease with subchondral sclerosis, osteophyte formation, narrowing of the joint, and disruption of the normal articular contour. And so there are lots of different grading of severity. Interestingly, the radiographic severity doesn't always correlate to patient clinical symptoms, because some patients can have very minor radiographic osteoarthritic disease but have very bad symptoms. Or some patients can have very severe radiographic evidence of osteoarthritis but not very much symptoms. So if we look into what causes osteoarthritis, it's more than just a wear and tear disease of overuse of a joint over a patient's lifetime. We know that when you get cartilage damage, that it leads to the recruitment of lots of different inflammatory factors. And then when you start getting erosion into the cortical bone as well, that also promotes inflammation. There's a variety of pro-inflammatory factors that get activated and anti-inflammatory factors get deactivated. And so this causes a lot of additional fibrosis as well as repair. And in fact, what we see is that when we get these inflammatory markers, we get neoangiogenesis. In other words, we get new microblood circulation forming, particularly around the synovium, as well as the eroded bone surfaces. And along with that blood vessel formation, we get formation of more nerves called neoinnervation. And it's the irritation of these abnormal nerve growths that causes a lot of symptomatic pain in osteoarthritis. And so part of osteoarthritic embolization is that we are trying to reduce this neoinnervation and neoangiogenesis. There are lots of treatment options out there for patients who do not want surgery. Things such as non-weight-bearing exercise, such as swimming, works very well, or even just losing weight. The next step is to then go on to medical management that includes oral anti-inflammatory agents, oral analgesia. We get some patients that then request injections, so we can inject directly into the knee joint analgesia or steroids. We can inject hyaluronic acid, which acts as a joint lubricant to try to reduce the amount of friction within the joint. There are some studies that says that we could do platelet-rich plasma directly into the knee joint. But beyond the medical management, the next step is going to surgery, where you end up with a joint replacement or a hemi-joint replacement where you replace just one side of the knee joint. And that's not really desirable for a lot of patients. Because when you perform a knee joint, the surgeons resect out, they dissect off the distal femoral condyles from the end of the femur. They also resect off the tibial plateau, and then they insert metallic implants that then go onto the ends of the bones, most often with surgical glue, and they place a small plastic spacer. So it's actually quite a major operation. And so a lot of young patients want to avoid this operation because there are lots of complications of surgery. And the issue is that not all joint replacements last. So over time, we know that we get joint replacement loosening, and that can cause further pain. And so when orthopedic surgeons perform a revision knee replacement, they have to resect more bone. So you'll see in these revision prostheses, the stem or the length of the metallic device is getting longer and longer. And so orthopedic surgeons end up taking out more bone. And in fact, if you go for a third revision, you sometimes need to place more femoral cables. We can see that in the middle picture on B. And it gets more and more difficult. And the other problem is that as the more revisions you have, the implant starts to last less and less time. So we know that with modern implants, the first joint replacement usually lasts anywhere between 15 to 20 years, depending on a patient's activity. We know that if you give a joint replacement to a young person and they start running marathons, that joint replacement is only going to last 5 years. When we start replacing more and more joint replacement, the replacement starts getting shorter and shorter, and then we start running into lots of problems. So that's where we can intervene with a variety of different pain interventions, such as a geniculate nerve block or ablation, where we destroy the nerves to the knee joint to help promote pain relief, or we can perform genicular artery embolization. So when we perform the embolization, remember I told you we are trying to reduce the amount of neovascularity, abnormal blood vessels, and also that will in turn get rid of the neo-innervation or the new pain fibers. And so when we perform this, we need to have a reminder of the anatomy. So there are lots of different arteries we need to be aware of, but the 5 major ones are the descending genicular artery that usually comes above the adductor canal, and it goes to the medial side of the knee joint. Importantly, that gives off the saphenous branch, and that supplies a lot of the skin over the medial side of the knee joint. So when we embolize through the descending genicular artery, we need to make sure we don't embolize that branch if possible. The other 4 major branches are both the superior and inferior, medial and lateral genicular arteries, as shown in the diagram here. Of course, life is never straightforward, so there are lots of anatomical variations. The middle genicular artery probably has the most variations. We can see here that it may come off different portions from the popliteal artery or the different medial or lateral superior genicular arteries. So we just need to be aware that there are lots of variations. And the other thing is that there are lots of anastomoses, areas where one blood vessel may anastomose with another. And there are lots of them shown here. You need to be aware of the majority of them. So these 5 are probably the ones that I would recommend you try to remember. With the most common being the M1 medial anastomosis variation. In terms of technique, it's very similar to what we do for any peripheral vascular disease. I usually prefer to have antegrade access, although you can go retrograde. I use a 4 French sheath, but you can use a bigger sheath. I know that Dr. Ukuno, who's a good friend of mine, uses a 3 French sheath. I commonly use a diagnostic catheter such as a Cobra C2, and I use selective catheterization with a microcatheter such as the Yasaki Flute, which is a 1.6 0.7 for each microcatheter, as well as a Sagi Maestro wire. But you can use any microcatheter combination. You want to perform your angiography to look for the excessive blush, what I will call it, and I'll show you some pictures. And what we try to do is that we're not trying to completely embolize the entire vessel. We are just injecting enough embolic to reduce the amount of blush, but not completely embolize the vessel, because what we don't want to do is cause bone marrow infarction, because that will lead to more osteoarthritis down the time. Dr. Ukuno initially described using imipenicillastin, so that is an antibiotic. And the reason why he chose that is that it's a crystalline antibiotic that dissolves. And so it takes about 30 to 45 minutes to dissolve in normal blood, so it's a temporary embolic. He now uses a Nexosphere, which is available in some countries. It's a Korean device, which is resorbable gel foam that's been calibrated to dissolve very quickly, quicker than normal gel foam. And a lot of centres around the world, particularly in Europe and the US, are using permanent particles such as BPA particles. There is also some data out of France looking at Blopaidol as a possible agent. So this is a case showing passage of a microcatheter down the femoral artery. This is entering the descending genicular artery. Here we can see the passage of the microcatheter further down into the knee joint. An angiogram shows that excessive blushing you can see here on the lateral side of the medial side of the knee joint. So that's all abnormal vascularity within the synovium. And when we perform the embolization, see if I can get the second video to work. So when we perform the embolization, we are not trying to completely block off the blood vessels. But what you can see here is we're not seeing that abnormal contrast blush anymore. And that's the endpoint we're looking for. And the volume is very small because this was only embolized with 0.6 mils of imipenicillastin contrast. So we need to be aware that we need to give very small amounts just to get rid of the neovascularity. We do not want to embolize all the blood vessel. Again, this is a few different areas. This is, again, an embolization of descending genicular artery. The other knee at the top, again, to illustrate that we're just getting rid of the blush. And an embolization of the inferior medial genicular artery. Again, we can see that contrast blush from that vessel. We only inject a little bit of embolic agent just to reduce that blushing. So a couple of tips. One is to avoid the cutaneous branches, and I'll talk about complications soon. But the saphenous branch of the descending genicular artery is one that we need to avoid, because that supplies the skin area of the medial knee. We need to be aware of anastomosis. So a few of you may remember that in the slides we had variants. So the most common variant is where the descending genicular artery anastomosis with the superior medial genicular artery. And so if we see that anastomosis, if we inject too much embolic down one of these arteries, it will then reflux into the other artery. And so we just need to be aware that if I go into the descending genicular artery and I inject my embolic agent, it then may travel through the superior medial genicular artery, go back into the popliteal artery, and end up in the foot. So in these instances, I go backwards, I go through. I'll try to show you this. So I try to actually cannulate the superior medial genicular artery, place my microcatheter here, and so when I inject, get reflux up this vessel, but avoid to try to get non-target embolization through the saphenous approach. So if we look at the evidence, it's a relatively new technique that Eugene Okuno only described back in 2015. So I won't spend too much time on this, but there have been 2 large systematic reviews on the few papers in this area. So this was published just last year, which looked at 9 papers, 339 Bs. And this other paper, which was published in 2021, that looked at 11 papers with 268 Bs. And what you can see in the results of both papers is that there is a decrease in the amount of pain as measured by VAS, which is the visual analog scale, as well as the WOMAC, which is another scoring system called the Western Ontario system to look at pain. And we can see that this effect of reducing pain is generally sustained up to 12 to 24 months. So we're seeing some early promising results from embolization. However, what we're also learning is that there are some patients who don't respond as well. And so those patients who have got full thickness cartilage loss, those with large bone marrow lesions such as subchondral insufficiency fractures or large areas of bone marrow infarction, or finally those patients with severe meniscal injuries, these patients don't do so well. And the reasons why these patients might not do so well is that with the full thickness cartilage loss, not only are you getting near innervation around the synovium, you're also getting it within the medullary bone that is actually quite difficult to treat. In patients with the meniscal injuries, we know the meniscus is not very richly supplied by blood vessels, so again it's very difficult to directly embolize the meniscus. So in terms of safety, there are 3 major complications we see. One is the cutaneous non-target embolization. So anyone that's performed this will know that when you inject into these small branches, you will get some going to the skin. And you can see here in a picture the before embolization on the left. We can see here in the middle, as soon as we perform the embolization, we see areas of redness of erythema and blotching within the skin. And approximately 1 hour after the procedure, a lot of this improves. So we find that the cutaneous non-target embolization is worse with permanent embolics because they don't dissolve. And secondly, what we can do is that we can put an ice pack over the knee during the procedure, and that helps to vasoconstrict the cutaneous branches, reduce the amount that goes towards the skin, and that also reduces the amount of this skin damage. The second is peripheral neuropathy. We know that there are some small blood anastomosis that goes to the tibial nerve, and there have been some papers in the US, particularly with these small permanent embolics, that there is a temporary neuropathy. And of course pain, because we don't want to cause skin ulcers. And in fact, complication rates are not insignificant. Cutaneous damage we see in about 12 to 18% of cases. A transient peripheral neuropathy about 10% of cases. And ischemic pain just from the embolization usually resolves within a couple of days. So in summary, I think this is a promising technique. Again, we still need more data, but it looks like that TAE really can offer a group of patients some pain relief for those patients who are not getting enough relief from medical therapy, or those who are not suitable for surgery. Potentially even young patients who may not want to avoid surgery. And so I think it's an interesting area. It's certainly growing very rapidly across the world as well as within Asia. And if there are people interested in this in Vietnam, I do encourage you to learn more about this. And thank you very much for Dr. Yuji Kuno who provided some of the slides. Thank you.
Thank you very much for